So now you see we have already done tonsillectomy on the left side. These are the vertical fiber. This is intracapsular dissection at the lower pole. So tonsillar artery is not exposed. Now I'm coagulating on the vertical fibers of the palatopharyngeus to take care of the lateral collapse. So as we coagulate at the setting of 3 on the vertical fibers of the palatopharyngeus, this area will become little more fibrosed and the lateral collapse would reduce. Now these are the oblique fibers of the palatopharyngeus which I am going to divide. So before dividing, I am coagulating on them as well. Okay, these are small blood vessels. So I am coagulating on the oblique fibers before dividing so that there is no bleeding. Now I am going to divide the oblique fibers of the palatopharyngeus, and this is a little bit of extra tissue which I am going to remove. Can you take care of this? So I'll possibly ablate these extra tissues. All right. All right. I've reached the muscles. Now I'm coagulating. These are the minor salivary glands. There's no point leaving behind tissues which are of no use. Now these are the oblique fibers of the palatopharyngeus. Can you take care of this tube? No. Take it out of my way. Take it out of my way, please. Correct. If you can do it more, that will be great. Thank you. Now I am dividing the oblique fibers of the palatopharyngeus as high as possible, and also dividing the mucosa along with sharply. Can you see that? Now there are still fibers of the palatopharyngeus which I need to divide sharply. All the oblique fibers are divided, and we'll rotate this flap laterally. Can you see? So this was the anterior wall of the pharynx. This will now form the lateral wall of the pharynx, and I have already coagulated all this area for fibrosis, and now I'll reinforce this area with the flap. So let me use the vicryl suture to reinforce the palatopharyngeal flap laterally. Now this is the pterygoid tubercle of the maxilla, and this is the mandible. This is the mandibular pterygomandibular raphe. I'm starting from lateral to the raphe, coming along the anterior pillar of the tonsil, again repeating not into the fossa, which we used to do earlier. So you get more vessels over there, and we want to ultimately pull the flap anteriorly and laterally. All right. Now, first full thickness bite into the palatopharyngeal flap. Can you see? Going outside the mucosa, into the mucosa, outside into the mucosa. All right. The second one, starting below, again full thickness. Space obviously is a little less. All sleep apneics, and this patient having a little retrognathia is again a little bit of challenge. But now see, full thickness right into the mucosa. Can you see this? Very, very gently. Now, idea is that this flap should remain laterally. I'll not pull it hard. I'll just direct it laterally so that the area, the bottleneck area at the top, which is the supratonsillar area here, this is the bottleneck. This area should remain open, and for that I had taken the flap laterally. Now, again along the anterior pillar of the tonsil, but while coming out, I'll remain medial to the pterygomandibular raphe. So by doing this, we'll use the whole strength of the pterygomandibular raphe to support. We'll not pull it very hard, only to support the pterygomandibular, the palatopharyngeal flap to remain lateral. Now see, very loose. And Dr. Patel will now step it. Okay. So the first knot was very loose. The second one will be a little tight. So I'm trying to give all the surgical tips. Make sure that you do not tear. Okay. The second one is a little tight, and the third one will be absolutely tight. Now this one has to be absolutely tight so that it does not open up. Now this one I have making it tight. Now you can release. Thank you. See how much of space is there below the first knot. Suture is cut a little long, little long. All right. Now I'll go back to my barbed suture. You see, it had just crossed the midline coming from the right. Can you take care of the tube? Thank you. Now again, starting 2 mm proximal, very, very deep. Let me see if I can reach the pterygomandibular raphe. Give me the artery. Thank you. If I can reach, well and good. I think I can. Yeah. So it's very important to do it the right way because this suture is going to stay in the patient's body for life. See, I have reached lateral to the raphe. All right. And now this suture from right to left, passing across the midline, will not let the soft palate go posteriorly. I will do a reinforcement. I have come from right to left. Now I'll go from left to right. Again, entering from the same place, very, very deep. All right. Now I'll go across the midline and go on to the right side and cut it off. Can you push a little more? Again, entering from the same place, very, very deep. So that it does not show up. and press it hard. Thank you. And all I want to do is to, I don't think I can reach the pterygomandibular raphe, so I'll come out. Okay. Now I'll try to reach the pterygomandibular raphe of the right side. Now this suture will make sure that the soft palate does not collapse posteriorly, and therefore there will be no snoring sleep apnea, and it will also support the base of the tongue. Uh, right, so I have reached lateral to the raphe, just waiting for it to come out in the correct place. If I would have shifted the tube, life would have been a little easier. That will take some time. This is not the exact place that it's coming out. I'm just waiting for it to come out in the exact place. Give me the artery, please. Alright, this is much beyond the raphe, which is fine. Alright, and before cutting it off, I'll just take a U-turn from here to further lock it. Gentle U-turn to further lock it. Because it's a one-way suture, so there need not be put any knot. Give me the scissor now. Alright, that's it. Now the end result of this suture and the surgery is that the extra length of the soft palate is taken care of in the anteroposterior part. So the AP collapse is completely gone. The uvula was still here. This length is gone. You can see a lot of space already built behind the soft palate. The tongue will fall on this suture, which is passing from right to left and left to right. So there cannot be any AP collapse here. This AP collapse is further, this flap is further augmenting the lateral collapse. We have already coagulated. So lateral collapse will be taken care of by these two flaps. Uh, and therefore both AP and lateral collapse will be taken care of. And when the tongue sits on the soft palate, it will not be able to go behind. But while swallowing, for the action of the levator palati, it's still free to happen. So there will be no velopharyngeal insufficiency, and the patient will be, getting a great improvement in the sleep apnea and snoring. Thank you for watching Suspension Bridge Pharyngoplasty.